Hammersmith is one of the 5 hospitals that make up Imperial College Healthcare NHS Trust. Retired carpenter John requires an operation to replace a valve in his heart.
If you're on the top floor, you might have a nice view.
John's procedure, known as a TAVI, a transcatheter aortic valve implantation, will be conducted by consultant cardiologist Iqbal Malik.
A TAVI is a way of deploying a new valve inside the heart without cutting the patient open too much. It's an insane thing to even consider, isn't it? A squashed valve goes into an artery. While the patient's awake, you track back to the heart and pop the new valve into position. The patient goes home the next day. That's something that would have been ludicrous to consider 10 years ago.
So you're 98?
And a half.
And a half. You've never had a stroke?
No.
You don't have diabetes?
No.
You don't look 98.
Thank you.
Age is just a number, you say?
Yeah.
At 98, John will be the oldest patient ever operated on by the TAVI team.
Some of the team is nervous that we'll be seen as lunatics doing a 98-year-old. Well, I don't think so. I'm the leader of the team. I don't think so. I think they can do what they like. I bet you when it's their granny, they'll be asking for a 98-year-old to have their TAVI done.
Have you done any other 98-year-olds?
That would be a no, I think. I think we're not far off it. I think we've done 95, but yeah.
And they survived?
They did, yes.
Let's go through the case. So he's 98. We know his creatinine's 200. It hasn't changed. The renal team's seen him. Don't want to do anything particular.
The average age for TAVI is 80. So these are patients who can't have open heart surgery. And a number of years ago, we couldn't offer patients anything. So now we're in a privileged position of offering TAVI to these elderly patients.
He's got so much more in him. He's still so full of life. My grandparents are my favourite people in the entire world, so I'm sure it's the same for everyone.
How many times have you been to hospital before in your life?
I had some varicose veins out when I was about 50 years ago now.
That was the last time you've been?
Yeah.
He's incredible. At the age of 87, he walked up Vesuvius. I think he only stopped running races against me and my brother around the age of 90. And he would try and win as well. This wasn't like he was trying to let us win.
She says, they haven't done anybody my age before.
But it's not about age, it's what we were saying to you before. It's not just about age, it's about how fit you are otherwise. You'll be running out of here.
3 choices. Give it up, give in, or give it your all.
It's now a good time to ask you what you'd like for Christmas.
I'd like to be alive.
Mr. Rowland. Hi, Dr. Malik.
Yeah.
Nice to see you.
Thank you.
OK, so can you hear me OK?
Yeah.
We've been through the risks before.
Yeah.
You know what we're talking about, but I
Yeah.
will double-check that you do understand.
Yeah.
Just as a short memory test, what is the problem that you had with your heart?
Well, get out of breath very quickly, you know, but
Yeah.
couldn't walk very far.
OK. In terms of risk,
Yeah.
if we did 100 cases, OK, then about 5 of them would have a bad problem.
1 in 20.
Yeah, and that
You
problem...
still had a problem with it. You mean the
Death.
to be dead.
Stroke, bleeding, heart attack. OK, is that an acceptable level of risk for you?
Yeah, well, I haven't much alternative.
OK. What's your date of birth, John?
March 1918.
1918, my goodness. OK, and can I just get you to sign on the dotted line, John, if you're up for having this procedure done? It's a miraculous treatment for the older patients that we couldn't treat before that we're now treating. Every cardiologist would hope to have one really important step that has suddenly changed in their lifetime that they can experience. And I think for me, at the age of 50 now, it's TAVI.
Demand for heart valve procedure TAVI has tripled at Hammersmith in the last 3 years.
What, the old valve? The other valve?
John is the second of these patients on Iqbal's list today. The first is a patient in their 80s.
Is that pressure real again?
Who are you calling?
Rex. Antonis wants to, it's bleeding too much, so he thinks he might want to open.
Okay, so this is an unexpected complication of the first procedure.
The first case hasn't gone according to plan because there's been some bleeding internally. TAVIs, you can't quite predict what's going on. Normally, they're very straightforward, and this is the first for the year where we've had a major complication.
It's now likely that the patient will need a post-operative intensive care bed. But that means one won't be available for 98-year-old John if his operation runs into trouble.
I'm trying to find another bed. Sometimes if they've got any capacity here, we can use one of their intensive care beds as a backup, fallback for the next case. Hello, are you the boss?
I am today, yes.
You may have heard we had a bit of a emergency in the first procedure today.
Yeah.
We've therefore lost our ICU bed, but we have a second TAVI.
Yeah.
We need a fallback critical care bed because he's 98, otherwise quite well, no previous surgeries.
We're full at the moment, 16 patients and 16 bed spaces. I'm sure 2 of the patients were going to go, and I think 1 was a cardiology patient.
So the deal is we have to take one back?
Yeah, there'll be a degree of swapping.
Okay.
We are in some difficulty in there. The bleeding's restarted, and therefore we can't really think about other cases. We have a senior surgeon operating, but I think the rest of the day in this particular lab is not going to be working out. I think we're going to have to cancel the TAVI. This is just not realistic. We're not even ready now, and by the time he gets on, it'll be 4. By the time we finish at 6, if something goes wrong at 6, we're much less covered. So I think it's safety first. Operating out of hours on elective cases that are high risk is not clever. I think if it all went well, I'd be finished by 5. You know, I think that's fine. But actually, if it didn't go so well, then the complication is being managed out of hours with, you know, less team around. I think it's unfortunate. So, old Father Time has defeated us. So I don't exactly, just your luck. But the thing that's destabilized us is a very rare eventuality. So sorry about today, okay? I'm going to get them to give you a cup of tea, give you some food, because we've kept you starved all day, okay? Okay. Okay, so I'm just coming down now. Yeah.
It's something I wasn't expecting. I was almost certain that it was going to happen today. But what can you do?
We know that there is a risk to doing the procedure, but we were told by the cardiologist without this operation he has a 50% chance of sudden death.
John will have to come back next week for another attempt at the procedure.
So we are going to attend the TAVI multidisciplinary team meeting, which is a meeting we have every week, essentially, to discuss all cases that we are considering for the TAVI procedure.
For a second time, consultant cardiologist Garda Mikhail is preparing for 98-year-old John's heart valve procedure.
So it's multidisciplinary, it's attended by cardiologists, surgeons, echo imaging doctors, CT doctors, so all the TAVI team. Okay, good morning. So the first case is Mr. John Rowlands, 98. This case was the case that we were supposed to do last week, and it got cancelled. So we're just rediscussing him because he's booked.
Can I just ask first?
Yes,
so 98.
98.
You need to persuade me that there is no frailty.
Can we just re-review the echo and the LV function? Sonthai, do you want to take us through the echo?
Sure. So,
yeah.
This is the first picture.
In many ways, we are, and the NHS is a victim of its own success. So we have so many elderly patients now. And we are getting into discussions about life expectancy when patients are already in their 90s. So he's got TR, but the PA pressure was up as well with a good ventricle. How do you explain that?
Overall LV function looks preserved.
With the TAVI MDT, it's particularly difficult because this is a high-risk group of patients. Cost does come into it, so I have a responsibility to manage the resources effectively. But actually, we try and pick the winners on clinical grounds, and we have to decide, does he have enough reserve to come through the procedure? Because I'm afraid it is the case that you can have an outcome which is a fate worse than death. So it is quite challenging. 147, is that a recent change? Or?
He's had increasing shortness of breath over the past 6 months. 6 months ago, apparently, he was walking about 4 miles, and now he can only walk about 200 metres. He's never smoked. He's got good lung function with severe aortic stenosis and slightly raised pulmonary artery pressures. He's got a very supportive family as well, who are all sort of on board with the TAVI.
He's just very keen to have something done. He wants to continue living and have a good quality of life and wants to be less symptomatic, but he's not low risk. At 98, he's not going to be low risk.
I'd want a clear statement that he understands that as well.
The last conversation we've had with him, he will accept risk just to feel better. Okay, fantastic. So he's all set. We can't be ageist. We are dealing with an aging population, and he wants a better quality of life. We can't deny a patient that, no matter what their age is.
You don't need to go quickly. We can just take our time. Enjoy the sense of déjà vu.
A week after he was first cancelled, John is back at Hammersmith Hospital.
You couldn't possibly say anything about quantity of life, how long we'll make him live, but he's a very active 98 and his quality of life has really got worse. It's very important that he's up for it, his family is up for it, and the team is up for it. So, can you just look up John Rowland's blood results? If any of the team had dissented, then we'd think again.
Yes. You want to sit on the chair, Grandad?
Okay.
Are you happy to be having the operation?
I'm not happy to be having it, but what's the alternative? Because I'm getting worse all the time recently. And I can only walk about... I used to walk miles, and now I can only walk a couple of 100 yards, and I'm out of wind.
I am genuinely terrified that something might happen to him because I honestly can't bear the thought of life without my granddad in it.
It's a rather large box.
It is, yeah.
And what's inside, Angela?
It's going to be John's new heart valve.
John's new heart valve has been shipped to Hammersmith from the United States.
It comes with lots of important kit to try and help us make it small enough to fit inside the body. So that's the actual valve itself. And we need to check we've got the right size. 26 valve, and it's the correct size we've got there.
The valve itself is the most expensive part. These TAVI valves cost anywhere between £12,000 and £18,000. And then there's the time taken for the procedure. And so I think if you wrapped up all of that, you probably wouldn't get much change from 30K, I would think. But it's cost effective because if he came in heart failure, he's likely to stay 2 weeks on the first admission, probably 10 days on the second admission. If he makes it to a third admission, it's probably another 2 weeks. You can see that very quickly we've got to beyond 30 days at £1,000 a day, and we're then going to be in credit. So we're not spending £30,000 on a patient because we fancy it. We're spending £30,000 not only to help him and his symptoms, but I would have a very strong argument that that is actually going to save the NHS money in the long run. Okay, Iqbal, the operator. Garda, the other operator.
Danny, anaesthetic nurse. Julie, anaesthetic fellow.
Gia, nurse.
Okay, fantastic. So there's a large team around, I'm sure.
Good team.
Good, a good, very good team. Thank goodness. Okay.
A lot of brains in this lot, must be.
Yeah, a lot of brains, exactly, a lot of brains. Some of them working as well. So, okay, so we've got your name sorted out. The procedure, it's a transfemoral TAVI. Right leg is the main access, 26mm S3 valve. We've just checked that all. Okay. So, John, you're part of the team. So we need to keep you nice and still.
Is that okay?
John will be awake throughout the procedure.
Okay, ready?
Okay, that's that pipe in. So John, we're just making a track for our big pipe to go in. Hopefully it's not too uncomfortable. Have a pair of forceps.
Basically what we're doing is we're going through the right femoral artery, which will lead us up into the heart.
Once the big pipe is in, we're pretty much committed to the valve, and so that's the time we take the valve. It's prepped over on the other table.
So that's what the valve looks like, and that's the 3 cusps.
We squash the valve into something the size of a big biro. And then as soon as we're ready to go, they'll hand it over to us, we can put it in.
Can I have the wire?
The clip.
Where did you take the clip?
So a bit of pushing now, John, bit of pushing. So it's quite a tough push because the valve is a bit like a goat in a boa constrictor. It's expanding as we go.
All right, John. Well.
Yeah. All right, you're doing very well. Right.
Okay, so everyone quiet. So ready to floor record. Pacing on. Balloon up, slowly, 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 slowly. Balloon down. Pacing off. Okay.
The pressure back. Okay. Let him recover. Okay, so there's the new valve here. It's in very good position, which is good. And we're going to put some colour on that. Oh, look at that amazing flow. Going forwards without turbulence, no leak coming backwards that we can see.
Okay, well done.
We've done this nearly 300 times, so it's like a Formula One pit stop, isn't it?
Hello, Dr. Mikhail. Oh, it's all done. We're all finished. It's all gone very well. All right. Do you want to look to the right? Yeah, just a bit slow to respond. Very, very slow.
John? John?
Show me that.
John?
All right, you still with us, John? 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 Hello there.
There we go.
Hi, John. I don't like that yawning. The yawning can be a marker of a stroke or something happening. The case is not over, I'm scrubbing back in. Most of the time nothing happens, our stroke rate is very low, probably about 1–1.5%. But absolutely for every patient, including me if I was a patient, if I'm dead, I don't really care. If I'm alive with a big stroke, I'm pretty annoyed about the whole situation. A stroke is not our biggest concern, but a stroke is not good.
John, just repeat your name for me. Can you do that? Tell me your name.
John, squeeze my fingers. Squeeze my fingers, John. John, move your toes. John, can you feel that? All right, John.
There's been no improvement at all since the TAVI finished, so unfortunately it looks, that he's had a neurological event. We've done all the tests to try and minimise the risk, and we didn't really think that his risk of stroke was going to be any higher than any other patient.
Hi, it's Dr. Malik here in the cath lab. I need to be put through to 999 London Ambulance to get a critical care transfer.
Time is of essence. If there's going to be any recovery, complication needs to be dealt with quickly.
They've had a stroke. We need to transfer with critical care transfer to the HASU at Charing Cross.
We're going to phone your family so they know where you've gone, right?
Yeah, we have a critical transfer from Hammersmith Hospital to Charing Cross HASU. We have a 98-year-old male who had a stroke during a procedure.
Oh, hi, it's Dr. Malik here from the Hammersmith Hospital. Unfortunately, there has been a complication during the procedure, and are you in a position to talk about that? Okay, so he's still with us. The problem is we think there's a stroke. So our only hope is that he's in that 1/3 that recover completely and not the 1/3 that do very, very badly. And we can't tell really at this very early stage which group he's actually going to be in. All right, okay, sorry the news is not better. No problem, no problem. Okay, all the best now. Bye now, bye.
All right, John, we're at the different hospital now.
John has been brought to the Trust's hyperacute stroke unit at Charing Cross Hospital.
I just came with them. Yeah.
Lift this right arm for me, please. John, your right arm. I know you're trying. Your right arm. Try your best. That one. Can you lift it up?
I'm just gonna extend your right leg to prevent any bleeding from your groin.
Sorry, sir. I'm just trying to check how good is your power. You probably had a stroke, we think.
Right-sided.
Right-sided weakness.
Yeah, there's the artery.
Yeah.
So just here, this is the middle cerebral artery, which supplies basically most of the left side of the brain. And you can see here, there's a bright spot here, which indicates thrombus, or clot, inside the blood vessels. And that would explain his right-sided symptoms, because it's actually a very important part of the brain. So losing that part of the brain would give him a significant neurological deficit.
What does that part of the brain do?
Well, certainly his more complex neurological functions, his power, sensation to the right side of his body. I think this would certainly be a candidate for thrombectomy. So let's get things moving.
Just 2 hours after his heart procedure, 98-year-old John must now undergo an operation on his brain.
We're planning to do a thrombectomy, which is where we go up through the blood vessels in the groin, up past the heart, through the neck, into the blood vessels of the brain, and the plan is to try and grab that clot, fish it out, and hopefully restore the flow of blood to that part of John's brain.
I've heard people describe thrombectomy as a kind of miracle cure to stroke.
Yeah. It is occasions where the stroke is severe.
At the moment, it's only Monday to Friday, 9 to 5?
Absolutely, yes.
So what happens outside of those hours?
Well, these patients are going to do as they have been doing up to now badly, unfortunately. Okay, John, doing really well.
So we've got a stent deployed where the clot is to try and grab it, and we've also got a big suction catheter to try and suck it at the same time. The older the patient, more twisty the vessels, certainly in someone who's 98. It's very difficult to get all the equipment up there. John, you're doing really well. Okay?
So if you see the stent, it's a very fine structure. It's like a cylindrical mesh.
So that's going into his
So that's
brain.
going into his brain, into the blood vessel where the blockage is. And by pulling it back, you're hoping that it's going to catch the clot. Nice and still, you're doing well, sir.
So we're quite deep now into the vessels, close to the limits of how far we can go. Ready still, John? The clot has migrated from the major trunk of the artery much deeper into one of the branches. The blockage starts about there. However, the clot probably goes beyond that, so it may not come back. We'll see what it looks like. Like some hard stuff there. This may well be clot from the heart. It may have calcium within it. It's much harder to pull out. Fingers crossed.
Ooh. Doing very well, sir.
I've got a tiny bit of something. Okay, John. We've got the clot out. Hopefully you'll feel better in a few minutes, okay? We have some clot stuck at the end of that stent. If you see here, at the end of the tubing, I don't know if you can zoom into, there's a black bit that's just come off there, a very dark bit. It's obviously blocked a major blood vessel that's supplying the left side of his brain. So now you can see that that area of brain before that wasn't filling is now filling.
It's amazing you can take that out.
Yeah, I mean, it works very well. It often does. It usually does.
All right, sir. All the best. I'll see you upstairs.
Hopefully, John makes a good recovery from this. All right?
There's another stroke that's coming in. It's just got off the plane.
Really?
Yes. So.
Okay. Another stroke. Let's do it.
one in, one out.
I was worried, and I was considering that perhaps I had been a little bit too positive in terms of the way that I presented things to him, that maybe it would have been better if he hadn't had the TAVI. Hello. How are you? How are you?
Not too bad.
Good. How has your day been?
It's been all right.
He's actually doing remarkably well, I have to say. He has had some initial problems with his speech and a little bit with his memory, and actually all of those things seem to be more or less resolved now. He seems to be back to his usual self. He is interested in the world again. We were having conversations about who his favourite Prime Minister was and who he thought was the worst Prime Minister he's ever witnessed in his lifetime. You're doing really well.
Thank you.
You're welcome.
When I was training, 65 was the cutoff for older age. That's a young man these days. Yes, it's getting busier, and the patients are getting older because they're surviving longer, which is a success story for UK and the NHS.
We've got all these amazing pioneering techniques, such as TAVI. But as the population ages, how sustainable is all of this within the current structure of the NHS?